We are back with another series. Let's revise PYQs. This will benefit you in your upcoming exam. Let's look at the first question from this video. Question 1. The provided image displays a partogram of a woman in the process of labor, who has already received an oxytocin infusion. Please describe your approach to managing this situation. Your options are, and the correct answer is cesarean section. Here's the explanation.
Now, partogram is the best tool to monitor the progress of labor. It is an early warning system. Please, partogram, best method to see the progress of labor. Many times this question has come. All right, MCI students, please mark this answer very confidently. Then, decisions taken if labor progress is slow. These decisions like contraction not very good, increase the oxytocin, known as augmentation. Okay, we can do that. We can also take a decision that send her to a bigger, better hospital, transfer her because we don't have the facilities of monitoring and this looks like it is getting complicated and slow, send her to a bigger hospital. Or this partogram also tells us that the baby is not well, the baby is getting into distress, or the dilatation is not happening for the last 3 hours and the descent is not happening for the 3 hours, it has gone into a cephalopelvic disproportion. Let's go ahead and do a cesarean section. So, termination of labor by a cesarean section, if there is a obstruction happening, all of that is also given. This information is also given by the partogram. So, please guys, interns, first is PGs watching this, please do not neglect the partogram. Okay, please make a partogram of any patient who's come to the labor room. Now, this is also one very easy method for me to come to the labor room when I'm doing my rounds of all the patients in the labor room. As a consultant, I come and you got some 10 patients in the labor room who are in active labor, and then I ask you what is happening to bed number 7 and what is happening to bed number 3, what is happening to bed number 9, and you don't know all the findings by heart of all the 10 patients, but you have all the 10 charts in front of you and you can show me how the partogram is progressing for all these 10 patients. One look and I know that you've been examining the patient, you've been mentioning the findings, and one look at the partogram I can say continue, continue, increase oxytocin, okay, see for another 2 hours and inform me if I have to do a cesarean, you know, this one do a cesarean. So we can make a decision just looking at the partogram. Of course, you should be monitoring them properly, then only you'll be able to make a good partogram. So when we do a partogram, they are, what are the particulars of the partogram? It is plotted to assess all events during labor. Okay, partogram is a very descriptive chart. I've shown you only the upper half of the partogram here. And this is just showing the fetal heart rate, the amniotic fluid color, the molding, and the cervical dilatation and the descent of the head. And apart from that, also there are many parameters like the uterine contractions, the maternal blood pressure, and the pulse rate, temperature, all that. So a partogram is plotted to assess all events during labor. The WHO modified partogram does not have a latent phase in it anymore. So if you see earlier, this graph which you're seeing, from 4 centimeters, you see a alert line. So this is the modified WHO partogram. Earlier, there used to be a latent phase like this, and then a active phase. So latent phase can be up to 8 hours. So the partogram used to get very stretched. So nowadays we don't have the latent phase, we only have the active phase of labor. Then points are plotted only in the active phase of labor. Partogram is started at 4 centimeters. Repeatedly I've told you, it's not 5 and it's not 6. Yes, labor care guide given by WHO says 5 centimeters. I know that. But labor care guide is a very complicated modification of the systems which are prevailing in the country. And it is freely available on the WHO website. Please download and start reading. Eventually, it's going to come. I think somebody is going to propose it in the Ministry of Health and Family Welfare. And probably it has already been proposed and people are deliberating on that. So if it comes, we'll start teaching you the labor care guide. But it's far more complicated. That's what I felt. If you understand it, nothing is complicated, but when you changes are a little difficult. So far, I think this is fine. As and when the labor care guide is implemented, we'll discuss about that also. I can always give an update to this app, but so far, please read that the active stage of labor is 4 centimeters. Then, now let us see bit by bit the parts of partogram, because that one big picture did not show all of those things clearly to us. Now let us see. First, we'll talk about the upper half of the partogram. Now, partogram, the WHO partogram basically says that, of course, you should have all the details of the patient, that name, whether she's a primigrada or a multigrada, she's a gravida 2, para 1 and live 1, like that. You should have the hospital number, date of admission, time of admission. So all of that is mentioned here. Now, when you see the fetal heart rate normally is 120 to 160. Now, the classical WHO partogram has darkened these lines. So, I have not done this here. Just to show you, they have darkened these lines. This one at 180 and this one at 100. So, WHO says that when you're monitoring the heart rate, suppose the heart rate is at 140 for the baby, then after half an hour it is again 140, then it is 150, 150, 140, 130, like that. The heart rate of the baby is like this. So your monitoring is like this. This is the heart rate of the fetus. But if it is more than 180 and less than 100 is definition of distress by WHO. But you see all the Indian partograms, most of the partograms in the hospitals, there they have darkened the line at 120 and at 160. All right. So yes, 120 to 160 is normal. Above that is distress and below 120 is distress.
Question 2. Identify the type of hymen shown in the image below. Your options are, and the correct answer is imperforate hymen. Here's the explanation.
Abnormal uterine bleeding is the cryptomenorrhea, where the patient is bleeding, but it is hidden menstruation. The patient doesn't know that she's having menstruation and she comes to you saying that she's never had periods in her life. She's a young girl, let's say 14, 15 years, 16 years. She says, sir, I've never had periods in my life. She comes to you with primary menorrhea. You examine the lady and you see that the hymen is imperforate, or it could be a transvaginal septum, which is a Mullerian defect. So let us see what is cryptomenorrhea. We mean hidden menstruation. Here, for example, I'm saying imperforate hymen is a condition where the uterus is formed, the cervix is properly formed, the vagina is formed, the upper vagina, lower vagina, just that the hymenal opening, this has not properly cannulated. So what happens that this woman, let's say at 12 years, she starts actually menstruating. When she starts menstruating, the blood will start accumulating in the uterine cavity and then it will also start accumulating in the vagina. So what happens in this patient? That there will be a distended uterus with menstrual blood. Now this menstrual blood which collects here, the patient will come to you with periodic pain, periodic abdominal pain. So presents with periodic abdominal pain because of this blood in the uterus, hematometra, blood in this vagina, hematocolpos. Colpos means vagina. But rarely the patient may also have a problem where she's having the blood accumulated so much that it is distending the vagina and that is distending the complete pelvis with a swollen vagina. So somewhere here is the rectum which has got compressed also. Now, if you see this vagina, I'm showing you a young girl in a sagittal section from the right side I'm showing you. So this girl who has got this pent up menstrual blood in the vagina, this is distended so much that this distended vagina will now compress this bladder neck against the pubic symphysis, and this patient will now have retention of urine because of this. She'll come and present to you with acute retention of urine. She'll come at 2 in the morning and say that she cannot urinate and she'll have a lot of pain. So yes, on history taking, you will find out that she had periodic abdominal pain and the parents had ignored, they had not seen the girl that she's not menstruating yet. So yes, this is what can be a presentation. Rarely the patient can come to you with, so yes, rarely a patient can present to you with acute retention of urine. So yes, that is how sometimes the patient actually come to you with. So this is what is a imperforate hymen causing a cryptomenorrhea. Mind you, imperforate hymen is not a Mullerian defect, it's a cannulation defect. Now, let me show you a video of a patient who had a imperforate hymen and what is the treatment of an imperforate hymen. All of you know the treatment of an imperforate hymen is to make a cruciate incision. You make an incision on the hymen like this. That cruciate incision, with that the pent up blood will come out. And after making that incision, you don't just make an incision and leave it. You have to evert the edges. You have to cut along the edges. So yes, along the edges you will cut like this. Like that. So finally the vaginal opening should look something like this. Alright, so let me show that video to you. So this is that video which I want to show you about imperforate Hammond, where we make a cruciate incision. So yes, this is that girl, and just like we said, we make a cross shape, a cruciate incision. And when we're making this cruciate incision, remember that this patient with the distended vagina and a careless incision can cause some injuries to organs like the urethra above. So you should have a catheter here to know where the urethra of this patient is. And then when we make this incision, we deepen this. And when you deepen this, you'll see what is coming out. You'll see that a lot of pent-up menstrual blood is coming out of this patient. Now remember, this patient was 16 years of age when she came to us with cyclical abdominal pain, and she had this acute retention of urine when she had come in the middle of the night. And when we made this incision, how much do you assume the blood loss is per month? Let's say she started menstruating at 12 years of age, and every month she'll lose around 50 ml of blood. So in a year, she should be losing around 600 ml of blood. And in 4 years, 12 to 16, she should be losing around 2,400 ml of blood. So you know how much blood came out in this patient? Exactly 2,200 ml of menstrual blood came out. So that's why it was almost the expected amount of blood. And she would have been menstruating for 4 years. Unfortunately, the parents never bothered to ask. There were many children in this family. They were living in a joint family in a far-off village. And that's what happens when these girls get neglected, and they had these problems of pain, but nobody actually bothered to find out whether this girl has even come of age. So yes, now we saw that this was the reason, imperforate Hammond, and the treatment is a cruciate incision. All right. Now,
Question 3. A 27-year-old female patient was found to have uterus didelphys. Which of the following is not likely to be a complication to this uterine anomaly? Your options are, and the correct answer is transverse lie. Here's the explanation.
Now, a didelphys can present with preterm labor again, but also can have a breech presentation at term, may also have endometriosis. Now, one thing you must understand, that a case of didelphys uterus is mostly a safe Mullerian defect. In fact, I can go ahead and say it is the safest Mullerian defect. So generally we give no treatment. Mostly we don't treat this defect, because this, I have enumerated these preterm labor and breech problems here. Suppose it's a breech at term, we can do a normal delivery also of breech, but yes, we can do a cesarean and give a healthy baby. So that's not much of a problem. It will give a full-term pregnancy at least. So with the didelphys, we say that it's a safest Mullerian defect.
Question 4. What is the most probable diagnosis for a woman who is 36 weeks pregnant and experiencing breathlessness, excessive abdominal distension, normal fetal movements, difficulty in feeling fetal parts, muffled fetal heartbeat, symphysis fundal height of 41 centimeters, and a tense but non-tender abdomen? Your options are, and the correct answer is polyhydramnios. Here's the explanation.
Now, what is the grading of the polyhydramnios? If it is just more than 25, that is what is known as the mild polyhydramnios, and that is the most common type of polyhydramnios. 30 to 35 is the moderate polyhydramnios, and more than 35 is the severe polyhydramnios, and it is mostly associated with the anomalies. Lot of anomalies cause the fetal anomalies cause polyhydramnios, notably the neural tube defects like anencephaly and all. So those anomalies cause this severe polyhydramnios. So what are the causes of polyhydramnios? Diabetes is that one major cause. We know high sugars in the mother, high sugars in the baby, and the baby is going to pass a lot more urine, and a lot more urine is going to cause a lot more polyhydramnios. Simple logic. Because of high sugars, the baby also has polyuria, and diabetes can cause, the mother's diabetes can cause the baby also to have high sugars and polyuria. Then esophageal atresia, duodenal atresia can cause polyhydramnios. Twin gestation is a classical cause. Neural tube defects like I discussed, cleft lip and palates, gastroschisis, abdomen not having any covering, transudation of fluids, that cause severe polyhydramnios. Duodenal atresia, choreangioma of the placenta are some of the defects which cause polyhydramnios. Then signs of symptoms are the distension. The abdomen is too distended. Obviously, the mother's diaphragm will not move down when she breathes. We all breathe like this, isn't it? Like that. So every time our diaphragm goes down, we get the lung to have an expansion. But if the abdomen is too tense with the amniotic fluid, then this movement doesn't happen. So mother has shortness of breath. So that respiratory distress, orthopnea, all of these are the problems of polyhydramnios.
Question 5. A 30-year-old female patient has a history of 3 miscarriages. Identify the investigation that was done to identify the cause from the image shown below. Your options are, and the correct answer is hysterosalpingography. Here's the explanation.
When we do the hysterosalpingography, we put a leech cannula into the uterus. See, this is a fluoroscopic picture of the pelvis of the lady, and I put a leech cannula. This is the Leech-Wilkinson cannula. We can read about this in the instruments chapter of the app. So the Leech-Wilkinson cannula is used, and this, when it is put into the uterus, so with the leech cannula inside the uterus, now we run the fluoroscopy. When we run the fluoroscopy, we'll see this view. Now, while this is on, we put some dye, a radio-opaque dye through the leech cannula. Now, that radio-opaque dye is known as the meglumine diatrizoate. Look, a lot of you keep saying the dye's name is urographin, tazographin. These are trade names. You have to know the salt which is used. So the generic name is the meglumine diatrizoate. So that is a radiopaque dye, and when that goes through this uterus, it will come through the fallopian tube, and if the tubes are patent, it will collect in the pouch of ductless. So let us see that video. So when you're doing the hysterosalpingography, you're injecting the dye here. Now you see, there's the buzz in the OT which I have kept for you. So under anesthesia, you should do it. You should give her some sedation or some intravenous anesthesia. And look here, this dye has gone inside. Now you see the fallopian tube here, see the fallopian tube there. So that is what is a good patent tubes. These are good patent tubes. All right. Once more, you see nice shape of the uterus you see, and the tubes coming out. And now, can you tell me one thing? Apart from the uterus and the tube, are you able to see anything else? Now, that's the limitation of a HSG. HSG is a good preliminary assessment of the tubal patency and the uterine anatomy. Not the best. Yes, a lot of women will have this assessment, and after this assessment, we give basic treatment and they conceive. Good enough. But yes, if there's a problem with the HSG, then you have to go and do the laparohysteroscopy. So laparoscopy and hysteroscopy is definitely better assessment of the anatomy of the uterus. But yes, a good preliminary investigation to find out the tubal patency is the hysterosalpingography.
Question 6. What should be the next course of action for a 23-year-old woman who has been actively trying to conceive for 6 months but has been unsuccessful, as she presents to the infertility clinic accompanied by her mother-in-law? Your options are, and the correct answer is reassure and review the couple after 6 months. Here's the explanation.
Infertility, is defined as the inability to conceive after trying with unprotected intercourse for a time of 1 year. Please, it's not 6 months, it's not 2 years, it is 1 year. There are a lot of books which say that less than 27, we should say it is 1 year, and after 27 years of age, it should be 6 months. All those definitions don't make any sense. This is the standardized definition across the whole world. 1 year is the definition, and that is the same for primary and secondary infertility. All right. So what is primary infertility? That the woman has never conceived. And secondary infertility is that a person who has had a previous child or had a previous abortion, whatever kind of a pregnancy, even an ectopic pregnancy she had earlier, and now she's not able to conceive, then again it becomes a secondary infertility. And in both the cases, whether it's primary or secondary, the duration is 1 year. Don't say that the duration for secondary infertility is lesser, right? Now, those are the definitions. Now, what is subfertility? When a couple conceives after trying for almost a year, that is delayed fertility, is what is known as subfertility. So, a lot of us have a problem of using these terms interchangeably, infertility and subfertility, which is not exactly wrong also, but it's not appropriate. Infertility is no conception. Subfertility is eventual conception after a long time. Right. Now, what are the chances of conception when a person has unprotected intercourse? Now, why I want you to show this slide? Let's come back to the previous slide. 15 to 20% couples are infertile. So why did I say that the couple is infertile when they have to try at least for 1 year? Why this 1 year? Just because me and my friends as gynecologists and infertility specialists feel like that? I mean, we just decided on a figure arbitrarily? No, these are population studies. And it has been found that when people stay together and have unprotected intercourse for a year, then 90% of these couples will conceive within 1 year of trying. So these are all proven population data which will tell us that they should wait for a year at least. Now, that's why we say chance of conception with unprotected intercourse, 90% couples will conceive within 1 year. In fact, 80% couples will conceive within 6 months of trying and 1 act of intercourse. So how did they probably come to this figure that 90% people conceive within 1 year of unprotected intercourse? Look, if a couple has intercourse just once on the right time of the month, let's say on the 14th day when she has documented ovulation and the man has got, let's say, 100 million sperms and they have intercourse on that good day, 14th day, what is the chance of percentage of a pregnancy there? That should be the best, isn't it? Best time and the best sperm count and the proven ovulation should be the best chance. How much is the chance that when they have intercourse on that day, pregnancy will happen? It is not anything more than 4 to 8%. So upper limit is 8% if they have just 1 intercourse. Now let us see from this basic information. If they have just 1 intercourse on the 14th day in 1 month, then next month the cumulative incidence of pregnancy will be 16%, third month will be 24%. And in 12 months, it will be around 96%. So that's why maybe I've oversimplified things, but this is probably the reason why we say that wait for a year at least. Even if they have 1 unprotected intercourse, then there can be a chance of up to 8 to 10% this 1 month. Then if they have multiple exposures in 1 month, if they have multiple exposure, chance of conception with multiple acts in 1 month is 25%. So that's why if they have multiple intercourse in 1 month and they try even for 6 months, 80% couples will conceive. So that's how they came to this figure of waiting for 1 year. But this is what I've taught you. This is what we practice in the outpatient department, but day in and day out, whatever happens, day in and day out, there'll be couples coming to us who will be, very recently married. Within 3 months of marriage or 4 months of marriage, they'll be coming to us for a pregnancy because the in-laws will be behind them that get to have a pregnancy as early as possible. So that's why please counsel them and ask them to wait for a year at least.
Question 7. While conducting a delivery, you perform the maneuver shown below. Following this, there is incomplete separation of the placenta and massive hemorrhage. What is your next step in management? Your options are, and the correct answer is manual removal of placenta. Here's the explanation.
Retained placental bed. Now, you have done the delivery of the baby and the placenta is still inside. Yes, I said what is the method of delivery of the placenta? You will do a control cord traction. See, this cord is here attached and you're doing a control cord traction. You do a control cord traction, doesn't come out. Then you do another control cord traction, doesn't come out. Then you do, you waited for 5-10 minutes and then you give a slight stronger jerk. Still it doesn't come out. In fact, the cord snaps sometimes. So when the cord snaps, okay, sometimes the cord will snap. This cord comes off and the placenta stays inside. So we call it a retained placenta. So if the placenta has not come out for more than 30 minutes, if the placenta has not come out for more than 30 minutes, we call it a retained placenta. And the management of a retained placenta is to put your hand inside and manually remove the placenta under general anesthesia, not in the labor room, not on the bed of the labor room. And on the labor room table, you've got 2 interns to hold the legs and 2 interns to hold the hands, and forcibly you put a hand inside in a woman who is crying and screaming with pain. Look, a lot of residents keep doing that. Please don't do it. It is against the law and some woman is going to sue you for doing that. All right. Please do not do such a painful procedure without anesthesia. Manual removal has to be done in the operation theatre. So give her under anesthesia. So yes, the management is put your hand inside the uterus under anesthesia and with the ulnar border. With the ulnar border, you will scrape the attachment of the placenta and take it out.
Question 8. A woman, who is currently 38 weeks pregnant, visits the outpatient department for a regular checkup. She had previously given birth to healthy twins at full term 4 years ago. What is her obstetric score? Your options are, and the correct answer is G2P1. Here's the explanation.
Examples of obstetric score. This keeps coming in your MCI and INI-CET exams very regularly. Gravida para live aborta. This is what is the more common method of assigning an obstetric score to pregnant ladies or to ladies, not just necessarily pregnant ladies, rather than the GTPLA. This is used only in some localities. Even when we read the American books like Williams Obstetrics, there also it mentions that it is used in some localities. It's not the more accepted method. So the more accepted method which came in the exam so many times is the Gravida para live aborta system. So let us see with some examples. So let's see the first example. A woman is pregnant, has one live child and no abortions. So we always start from the reverse, always start from the back. So if we say there are no abortions, we say there is a 0 and live, one live child. So it is very simple, one live child, and she is pregnant as of now. So she is a pregnant lady, she is a gravida. Now she is pregnant, has one live child, no abortions. So if she's got one live child, obviously she would have delivered one pregnancy, which is after 28 weeks. That's why the baby is living. So that's why we say para 1 live 1. She delivered one child and that child is living and there's no abortions. And now she's pregnant. So she's delivered one child which is living. She's delivered one child which is living. Live is part of para. Don't get confused, please. This is where you get confused sometimes, that para 1 live 1 means there are two pregnancies. No, no, no. Don't think that way. She has delivered one child and that child is living, live 1. If that child was dead, we'll say para 1 live 0. So live is part of para. Don't add para and live. So she's delivered one child and she's pregnant again. So this is gravida 2. It's a very simple way. I say, look at your neighbor. Look at your neighbor. She's pregnant for the second time. She's got a one live baby. So she's a second gravida. She's got one live child. That means she had delivered that one live child after 28 weeks. That's why the baby is living. So she's got one live child and now she's pregnant again. So obviously it's a second pregnancy and she's got one live child. So she's delivered one. That is para 1. Is it living or dead? It is living. You can see the child running around in your locality. So that's why she's gravida 2, para 1, live 1. So I always say, just imagine your neighbor who is pregnant, and that way you can correlate with these examples very easily. So this is the easiest example which I've given you. Now let's see the next one. Woman is pregnant, so she's a gravida, has 2 living children. So live 2 already, but she had 3 term deliveries. What is the meaning of that? She has delivered 3 children. So para already we know it is 3 and has 1 abortions. So when she has 1 abortion, we say always start from the reverse. A1, that is 1 abortion, 3 term deliveries and 2 living children. So live 2 and para 3. 3 term deliveries. She has delivered 3 viable babies. So para 3. How many of them are living? Living are 2. So live 2. And I have told you live is part of para. So when you're going to write the gravida, in this case, do not add these 2. These 2 are never added. Of course, when you're writing the gravida, you have to add the number of deliveries and the number of abortions. These 2 are definitely added. So she's aborted one child. She was obviously pregnant then and she aborted that child before 28 weeks. So abortion 1. And she delivered 3 babies. Live or dead, I'm not bothered. She's delivered 3 babies. So how many pregnancies in total she had before this? Para 3, 3 children after 28 weeks and 1 abortion. So she was pregnant 4 times before this, out of which 2 babies are living, 1 has aborted. So net number of pregnancies is adding the para and aborta. That means she's had 4 pregnancies before this and now she's pregnant again. So if she's had 4 pregnancies, then it is a gravida 5 as of now. Please, these are very simple examples. And if you feel that you didn't understand, please reverse and please rewind and please see them once more, because these are coming in exams and I don't know, unnecessarily don't get confused. Now let's see one more examples. A woman is pregnant, that means she's a gravida, has 1 delivery, para 1, and she has 2 live children. How is that possible? So no abortion, so we don't write anything about abortions. Has 2 children who are living, live 2. But I have already written here, she's had 1 delivery. When the exam question is already mentioning that she's had 1 delivery. So you don't have to write para 3 or para 2. 1 delivery. So para 1. 1 delivery, 2 living children. How is that possible? Because she delivered 2 babies in the same delivery. That's why we say in twins, the act of delivery, she has a case of twins previously. When a woman delivers twins, the act of delivery is only once. She's delivered today. Today she's delivered once and 2 babies came out of this delivery. So para 1, live 2. So she was pregnant once and she's delivered once and she has 2 babies out of that because it was a case of twin gestation. Now she's pregnant again. So tell me, what will the gravida come? I already told you, do not get confused and don't add para and live. Live is part of para. So she was pregnant once, she's delivered once. That's all. Now she's pregnant for the second time. So that's why we say gravida 2, para 1. Don't say gravida 4. Don't add para and live. That is going to give you a wrong answer. Please don't add para and live. Okay. Yes, you will add para and abortion, but since there was no abortions, that's why it is para 1. Now she's pregnant for the second time. Gravida 2, para 1, live 2. This came in your NEET exam, the twins example. Then this also, I think something similar came in the MCI exam also. Now, a 69-year-old lady, she has 3 living children and 3 have died. That means she has 6 deliveries we can make out and 4 abortions. So A4, 4 abortions written, 3 died and 3 live. So live is 3, but 3 died. So net number of deliveries, how many? 3 living and 3 died. That means she's saying that she delivered 6 babies and out of them 3 died because of whatever reasons after they were born. Suppose they were born and died within 1 week of delivery, neonatal death. So it is 1 delivery and died, para 1, live 0. But she's delivered 6 and 3 have died for whatever reason. So that's why para 6, live 3, A4. Now what about gravida? Please, I have not told you she's pregnant. And please remember, she's 69-year-old. She cannot spontaneously conceive also. So when a woman who's 69 and comes to you, you are a final year student and you are taking history, she's got a prolapse and she says she's delivered 6 children in the village and that's the reason, probably abnormal conduct labor is probably the reason of a prolapse. Now you go to the examiner and say she's gravida 7, para 3, live 3 and the examiner gets really furious. How can you call her gravida? You cannot call her gravida till she's pregnant, and definitely a 69-year-old lady cannot be pregnant. Okay, so don't do these basic mistakes. You don't have to say a gravida when the lady is not pregnant. So you say she's a para 6, live 3, A4. That's what you say to the examiner. She's a para 6, live 3, A4. She delivered 6 children in the village and the last delivery was, let's say, 25 years back. Now she's come with a mass descending per vaginum. That's how you present your history. Please don't say she's a gravida. That will really get the examiner irritated. All right. Now let's see one more example. There's a 33-year-old lady who's got 3 living children and 3 died and 4 abortions. So 4 abortions, 3 died and 3 living. So live 3 and she delivered 6. 3 live and 3 died. That means she's delivered 6. So same example, but she is 33 years. So will you put a gravida? No, you will not put a gravida. Still, the formula stays the same. Because she is 33 years, she can be pregnant. But you will not put a gravida till she is actually pregnant and carrying a pregnancy. So yes, either way, don't put a G till she's actually pregnant. All right. So like I said, there's a GTPAL system also. It's just that the gravida, para, live, aborta system has been split into GTPAL system, where para, I told you para is a baby delivered after 28 weeks. The woman attains parity when she delivers a baby after 28 weeks of pregnancy. So that is para. So para has been split into after 28 weeks if the baby was born at term, that is 37 to 42, or was born before 37 weeks, that is preterm.
Question 9. Which procedure from the provided list of diagnosis is the most suitable for performing a hysteroscopy? Your options are, and the correct answer is Asherman syndrome. Here's the explanation.
HSG will show you filling defects. Now, apart from the ultrasound, what are the other methods of doing the diagnosis of Asherman syndrome? We can use the hysterosalpingography. In the hysterosalpingography, you'll see filling defects. Now, this is a old, radiograph of the pelvis where we have done a hysterosalpingography. In this hysterosalpingography, you're seeing the tubes here normally, and also here you're seeing the tubes. But inside here, if you can see, there's a small filling defect. So classically in severe Asherman syndrome, you'll see many filling defects, but this is the one authentic picture which I had with me, so I thought I'll show you. So that's the filling defect, and generally you get the picture about hysterosalpingography in your exam. I've seen the last few exams, 2 of MCI exams and 1 of NEET exam, you got a picture where hysterosalpingograph was shown to you where they were filling defect. So yes, ultrasound showing fibrosis and hysterosalpingograph showing you filling defect. They are 2 common methods. But you know what is the best method? These 2 are good methods, but the best method of diagnosing Escherman syndrome is by the method of hysteroscopy. Now, when you're doing a hysteroscopy, see here, in a hysteroscopy, you'll have a direct visualization of the bands of adhesion. Look, you're doing this and straight away I'm showing you the fundal bands here, and then on the side there are some bands of adhesion. So these bands of adhesions are best seen on the hysteroscopy, and you know what, I'm doing the hysteroscopy, I'm seeing these bands of adhesion. This is also the best time to remove these adhesions. So that's why when we come to the treatment, the best treatment of Escherman syndrome is to do a hysteroscopic adhesiolysis. All right.
Question 10. After a routine vaginal delivery, a patient experienced atonic postpartum hemorrhage. The patient was subsequently transferred to the operating theatre, where the obstetrician decided to perform vessel ligation to control the bleeding. Could you please provide the sequence in which the blood vessels supplying the uterus should be ligated? Your options are, and the correct answer is uterine artery, ovarian artery, internal iliac artery. Here's the explanation.
Obviously, the blood supply to the uterus is reduced by these procedures. So yes, this question also came that, look, it is common sense that you're going to tell me, sir, if the bleeding is not stopping, then we're going to stop the blood supply to the uterus by, we ligate the uterine artery, then we ligate the ovarian. If nothing works, then we'll go and ligate the internal iliac. So this is common sense. But they just twisted the question asking, what are the steps of uterine devascularization in one of the NEET exams recently? So step is, first is the uterine artery. So you understand that very well, that how is the blood supply, that this is the pelvis. So the internal iliac artery here, of course the external going like this and becoming the femoral later. This is the common iliac. So internal iliac is going to give the uterine artery here. So yes, when you are going to stop the bleeding, first you think of the uterine artery ligation. So you do the ligation here. But you also know directly from the aorta there is a branch. Directly from the aorta there is a branch which is the ovarian artery. It is giving blood supply to the ovary, but a lot of it is also giving blood supply to the uterus. There is a good anastomosis at this area. So you will ligate the ovarian artery also, right? Now, if this does not work, then you have to go ahead and ligate the internal iliac artery. I'll give you a much better picture than what I've drawn here, don't worry. So I'm just trying to tell you what are the steps of devascularization of the uterus.
Question 11. You are examining a multigravida in the second stage of labor for the past 2 hours. On examination, contractions are adequate. The cervix is dilated with the head at station 0 with molding 2+ and caput 2+. The sagittal suture is in the right occipitotransverse position. The fetal heart rate is 140 beats per minute. Which of the following is carried out for the management of this patient? Your options are, and the correct answer is lower segment caesarean section. Here's the explanation.
The upper segment of the uterus will contract. This area will contract to push the baby down, and to allow the baby to go down, the lower segment retracts. This segment relaxes. So that's the anatomical importance of the upper segment and the lower segment. So if you imagine my hands to be the uterus and my palms to be the cervix, so when the upper segment contracts and the lower segment relaxes, you can see with my hand that if there's a baby inside this uterus, then this baby will move down. Suppose upper segment and lower segment with both contracting, then the baby will stay where he is. But if the upper segment contracts and the lower segment relaxes, then the baby goes down. So that is why this upper segment and lower segment, this physiology of the contraction in labor has to be understood. So this upper segment contracts and the lower segment relaxes to help the baby go down. So at this level, you'll see a physiological retraction ring. All right. Now, if there's an obstructed labor, then the uterus is contracting much more. The uterus contracts more and contracts more and contracts more. So much of tonic contractions, the uterus gets bunched up because the head is not going anymore. It's not progressing in labor. Head is not going down. So when the head is not going down, in spite of good uterine contractions, we say it's an obstructed labor. So uterus goes on contracting and these muscles of the upper segment will bunch up. So that is going to now make a pathological retraction ring. Can you see this pathological retraction ring is not at the same level. It will not be straight. It will be a little oblique. All right. So yes, this can be felt. It can be felt per abdomen. All right. And also per vaginally. But this physiological retraction ring, when you put your fingers in the vagina, then only you can feel it. It is not felt. It is not felt per abdomen. A physiological retraction ring is formed always in labor and can be felt only through PV. It can be felt through a per vaginal examination. But a pathological retraction ring can be felt per abdomen. So this pathological retraction ring is higher and can be felt per abdomen, and it is known as the Bandel's ring. All right. So that is the information which I gave you. And the area between the anatomical interloss and the histological interloss is known as the isthmus, which later becomes the lower segment. All of that notes I have given to you. And then this information which I have given in the previous screen, I have written it here for you for the purpose of notes. All right. Then what else is the importance? Yes, I forgot to tell you that when we do a cesarean section, of course, it's been discussed in great detail in the chapter of cesarean sections. But once again, when the upper segment and the lower segment is formed, and suppose I end up doing a cesarean section for whatever reason, I always do the cesarean section in the lower segment to deliver the head of the baby. Why is it that? Because this lower segment where I make a scar, then next time when she goes in labor, I can give a trial of normal vaginal delivery. Why? Because the lower segment you've given a scar, and next time if you give a labor, don't be worried, it will not rupture. Why? Because the upper segment, suppose she had a previous cesarean, now this time she is having a trial of normal vaginal delivery. So upper segment is going to contract, and the lower segment where you've given the previous time you did an incision in the uterus, in the lower segment, that area is not taking part in a contraction, that area is taking part in a relaxation. So when a thing is relaxing, it will never rupture. So that's why we give a lower segment cesarean section. We of course discussed this in the chapter of cesarean, but once more, why to give a lower segment cesarean section? So that next time you can give a trial of normal vaginal delivery. So that is also mentioned in the notes here.
Question 12. What is the probable diagnosis for a woman presenting with pain and swelling in the perineal area, along with difficulty in walking and sitting? The patient reports a history of engaging in sexual activity with multiple partners. A physical examination reveals a tender swelling and redness on the labia, as depicted in the provided image. Your options are, and the correct answer is Bartholin abscess. Here's the explanation.
Bartholin cyst can form because of obstruction of the gland, and the Bartholin cyst you can do a drainage. You can do a drainage by a Word's catheter. A Word's catheter. You know, you put that catheter into the cyst, and slowly this collection in this the Bartholin cyst will slowly keep draining off, and you can pull out the catheter every 2-3 days a little bit, so that the gland now collapses and there's a small sinus made finally when you remove the catheter, and then this gland dries up. So this Bartholin cyst is drained by a Word's catheter. Now what can be done for a infected Bartholin cyst, which is a Bartholin's abscess? It's a very painful emergency. It's a painful emergency. Many women with Bartholin cyst abscess will not wait for you to electively post, because they'll have so much of pain. They'll come in the middle of the night or maybe late evening, and they'll want this to be treated at that time because she's having severe pain. So yes, you'll have to do a treatment under general anesthesia, or maybe a spinal block. You'll have to give a good anesthesia. Don't try to do a local anesthesia here. First of all, an abscess, around the abscess, the local won't work too well. So it's best that you give a spinal anesthesia, or better you give a GA and do a quick job of making this treatment of the Bartholin's abscess. Now, if there's a Bartholin's abscess, how do you treat this abscess? Please remember, most of the abscesses which you've seen, of course, your surgeons have taught you well, that an abscess you can do incision and drainage. Much like that, we do an incision drainage here. But slight modification is there. You can imagine the vulva of a lady. If you make an incision in the vulva and then you leave it open, of course, all abscesses, you will not suture them close. But you left this open. But when the woman stands up, like the way I'm standing, so the vulval skin and the thighs will approximate, and this incision which you made, you drained it properly, but the mouth of the incision will close by itself. And that's why this patient may have a recurrence. So that's why we say, suppose you imagine my, I'm cupping my hand to show you a bathroom abscess. You make an incision, see, the pus comes out. After the pus comes out, definitely you're not suturing it. But what you do actually, you evert the edges. See, you evert the edges so that the interior of the cavity is always exposed. So that's why this is known as exteriorization of the cavity. Yes, the treatment of Bartholin's abscess is known as marsupilization. Marsupilization means exteriorizing the cavity. All right, so that it doesn't close and it finally dries up. So that is what is done for a case of a Bartholin's abscess.
Question 13. Please identify the area in the image below that appears blue in color. Your options are, and the correct answer is mid-pelvis. Here's the explanation.
There is this greatest pelvic dimension. It goes from the middle of the posterior pubic symphysis, okay, middle part of the posterior pubic symphysis, to the junction between the second and third sacral vertebra. All right. So the sacrum here, the second and third. Can you see? It is maximum concavity here. Maximum concavity is here at the level of the second and the third sacral vertebra. Maximum concavity is there. So it is the greatest pelvic dimension, right? So from the back, see, from the back of the pubic symphysis to the junction of the second and third sacral vertebra, can you see? There is maximum concavity here. So there is maximum space in this area. And laterally it passes to the center of the acetabulum. Laterally, see, laterally it passes to the center of the acetabulum and upper part of the greater sciatic notch. Okay, upper part of the greater sciatic notch. So center of the back of the pubic symphysis, center of the acetabulum and the greater sciatic notch and second and third sacral vertebra. So that is the plane of greatest pelvic dimensions. Now then there is a plane of the least pelvic dimensions. Now least pelvic dimensions is from the lower part of the pubic symphysis. Least pelvic dimensions from the lower part. See, again I am showing you from the lower part of the pubic symphysis, and it goes laterally. It goes laterally to the ischial spines and then to the tip of the sacrum. See, not the coccyx. So I have removed the coccyx. So from the back of the pubic symphysis, laterally the ischial spines and to the tip of the sacrum. That is the least pelvic dimensions. All right. So that's what is written here also. So least pelvic dimensions here from the lowest part here to the tip of the sacrum, not this coccyx. We are not talking coccyx, tip of the sacrum. So this is the zone of the mid pelvis. All right. The area between the greatest pelvic dimensions to the least pelvic dimensions is the zone of the mid pelvis.
Question 14. Which of the following is an absolute contraindication for the insertion of the device shown in the image below? Your options are, and the correct answer is trophoblastic disease. Here's the explanation.
Contraindication of IU series, definitely when a lady is pregnant, having sepsis, STD, PID, undiagnosed vaginal bleeding, fibroids, uterine anomalies. I didn't write fibroids with excessive bleeding. All right, cancer of the cervix, cancer of the uterus. Absolute contraindications. Look, I did not say ectopic pregnancy as a contraindication here. Please note.
Question 15. A 20-year-old woman presented in the OPD with 7 weeks 2 days of gestational amenorrhea, not willing to continue her pregnancy. What are the drugs used for medical termination of pregnancy according to MTP Act? Your options are, and the correct answer is misoprostol and mifepristone. Here's the explanation.
The first trimester till 12 weeks. So what are these methods we can do? In the first trimester, we can do medical abortion just by using tablets. The patient can take these tablets and do this abortion after, of course, under the supervision of a doctor. We can give her these tablets and she can go home and she can have a bleeding at home and she can expel the products at home without being in the hospital. So that's why it is a very convenient method of doing MTPs. Medical abortion, you can give tablet mifepristone 200 milligrams orally. Now mifepristone, you know, is a anti-progestin. It's an anti-progestin, and that kills the fetus. Then 24 to 48 hours later, you can give misoprostol. Now you know misoprostol is PGE1, and this is given 800 micrograms vaginally. Please see this. This dose is in milligrams. This is in micrograms. Don't keep getting confused about these.
Question 16. A patient came to the gynecology OPD with complaints of foul, smelling frothy vaginal discharge and intense itching. On examination, the cervix and vagina were spotted and had the appearance of a strawberry. Identify the causative organism. Your options are, and the correct answer is Trichomonas vaginalis. Here's the explanation.
Both are in alkaline pH, and remember that when the patient has trichomoniasis, she has severe irritation, severe pruritus. And when we talk about candidiasis, she also has out of proportion pruritus. But remember, bacterial vaginosis has no itching. Major MCQ. Then when we talk about bacterial vaginosis treatment, the drug of choice is metronidazole, but in trichomoniasis is also metronidazole. Here we give it to both man and women, because trichomoniasis, when a woman has trichomoniasis and she has intercourse with a man who is not affected by trichomoniasis, with the intercourse there is a 70% chance. A man having intercourse with a woman having trichomoniasis, one intercourse has up to 70% chance that the man will be infected. And these trichomonads, the trophozoite forms, they tend to stay under the prepuce of this man, and he can reinfect his partner. You may treat the partner alone. So please remember, trichomoniasis, both man and woman should be treated.
Question 17. How would you approach the management of a 27-year-old pregnant woman who is at 36 plus 6 weeks, with a history of 3 pregnancies and 2 deliveries, and is currently presenting with a fetus in a transverse lie position? The ultrasound report indicates adequate liquor and a normal placenta, and there are no other risk factors present. Your options are, and the correct answer is external cephalic version. Here's the explanation.
So what is the lie of the baby? Now, lie of the baby is the vertical axis of the baby in relation to the vertical axis of the mother. Suppose I am the mother and this is the baby. Look, this is the vertical lie, although this is a breech presentation. This again is a vertical lie in a cephalic presentation, and this is a transverse lie. Now you see the shoulder is in the lower segment in a transverse lie. So lie, the vertical axis of the baby, the vertical axis of the baby in relation to the vertical axis of the mother is known as a lie, right? So here you're seeing the first one is a vertical lie in cephalic presentation. In breech also it's a vertical lie, and this is a transverse lie. In transverse lie, what do you see? You see a shoulder presentation. All right. So suppose these 3 come to you in labor. Suppose these 3 come to you in labor. So what will happen? Cephalic presentation will obviously deliver. I'm writing DEL. Now breech will also deliver. All right. This will also deliver, but in a institutional setup. In an institutional setup. Why? Because there will be a senior doctor present there all the time. There will be a senior obstetrician, a consultant level doctor who is much experienced in doing breech vaginal deliveries. And if the breech vaginal delivery is not successfully progressing, then why an institute is important? Because even at middle of the night, let's say 2 AM in the morning, you can do an emergency cesarean section if it is required. So that's why we say it should be done in an institutional setup under a senior obstetrician. Yes, breech will deliver normally. All right. Please, the art of normal delivery itself is getting lost. So art of normal breech vaginal delivery is getting very rare. But yes, you are definitely asked questions about breech vaginal delivery. Please, it is an art which an obstetrician is very proud of. Yes, breech vaginal delivery can cause more fetal injuries, but in the hands of a senior obstetrician and with good selection, it can be a very safe vaginal delivery as well. All right. Then shoulder presentation in a transverse lie. Now we are talking about all of these 3 if they come in labor. If a transverse lie with shoulder presentation comes in labor, please guys do a cesarean section. do a cesarean section, and there's no other option to this. Please don't spoil this MCQ. Transverse lie in labor, cesarean section, end of discussion. MCI students, these are those simple questions sometimes they ask you, and we get confused that, sir, is it in labor or not? Look, the question is very clear in the exams. If the patient is in labor and is in transverse lie, don't do any stunts, go ahead and do a cesarean section. All right, I have repeated this thrice already. Now, suppose these three patients are not in labor. Suppose these three patients are seen in the OPD at 36 weeks of gestation where the uterus is relaxed. So yes, cephalic presentation, nothing to do. Come next week and we'll do a pelvic assessment because it's a cephalic presentation, things are going fine. Suppose it's a breech at 36 weeks of gestation. When there's a breech at 36 weeks of gestation, you feel that yes, I'm a senior obstetrician and I can do a breech vaginal delivery. But I also know that there'll be more chances of injuries with breech vaginal delivery. So yes, why don't I just hold this baby, see, from the mother's abdomen. I take her to a place where I have an ultrasound machine. One of my friends is holding the ultrasound machine and I can see the baby through the ultrasound machine and see the heart rate, and I hold the baby and turn the baby under ultrasound guidance and make him cephalic. So that is what is known as a version. What are we doing? We are doing a external cephalic version. So in this uterus, you can turn the baby. Mostly we do a forward flip. The head forwards, we want the baby to turn. So yes, we can do a external cephalic version. External cephalic version can be done at 36 weeks. Why can it be done at 36 weeks or 37 weeks? Because the uterus is relaxed. When the uterus is contracting and the patient is in labor, you cannot turn the baby. And if you turn the baby, you may cause an abruption at that time. So that's why we do at 36 weeks, because the uterus is relaxed and liquor is reducing at this time. So when the liquor is reducing at this time, your version is likely to be successful and the baby will stay turned. Look, if you do this version, let's say at 32 weeks or even at 30 weeks, you say that it is a breech baby and I don't want a breech baby in this patient and I want the baby to be turned. So this is a breech and it's a small baby at, let's say, 30 weeks of gestation or 32 weeks of gestation, and you turn it. At 32 weeks, 30 weeks, the liquor is still increasing. At 32 weeks also the liquor is increasing. Sometimes it increases till 34 weeks. So now you have turned this baby. With the liquor increasing, the baby will go back to his preferred breech position. All right. So chances of failure is very high. So that's why when the peak levels of the liquor reaches at around 34 weeks, 32 to 34 weeks, then it starts reducing. So at 36 weeks, the liquor is reducing. The peak is 1000 ml at 32 to 34 weeks. At 36 weeks, it is 800 ml. So that's why uterus is relaxed and the liquor is reducing. That is the indication where you can do a external cephalic version easily. Similarly, if the uterus is relaxed and you see a transverse lie, again you can do a external cephalic version. All right. So this is the simplest method of the MCQs which come in the
Question 18. What is the most frequent complication observed in a teenage patient with a history of dysmenorrhea and chronic pelvic pain, who is found to have a transverse vaginal septum on ultrasonography? Your options are, and the correct answer is endometriosis. Here's the explanation.
Endometriosis. So the most common symptoms of endometriosis are the pain, and the pain, abdominal pain is there, but the severe pain which comes during the periods, the dysmenorrhea. So yes, chronic abdominal pain and monthly exacerbation presenting as severe congestive dysmenorrhea or the secondary dysmenorrhea. Pain starts 3 to 4 days before the onset of periods and stays throughout the menstruation. These girls with endometriosis, literally, what I know in my, call duties which we used to have in obs and gynae, we'll see these girls literally jumping with pain. So much of pain that the parents are so upset with the patient who presents, and we so many times have to give them injectable painkillers to get rid of this discomfort which they have. So very severe dysmenorrhea, congestive dysmenorrhea is classical of endometriosis. Then dyspareunia. Those who are sexually active will present with pains that they cannot have sex anymore. This could be one of the reasons leading to infertility. Why can't they have sexual intercourse? Because of dyspareunia. Means these deposits, they might be in the uterosacral ligaments, they might be in the pouch of Douglas. So it hurts her to have intercourse. So deep dyspareunia, that's what we say. One is penetration dyspareunia, that is when a person starts intercourse. While there is penetration, if there is pain, that means there is some vulvitis, vaginitis. Deep dyspareunia is when intercourse establishes and then the deposits in the pouch of Douglas, in the rectovaginal septum, in the ligaments, they hurt the lady a lot with the intercourse. So deep dyspareunia is a classical presentation of endometriosis. And then menorrhagia. All of you know, the first thing in this chapter I told you, high estrogens cause endometriosis, and high estrogens also cause hyperproliferation of the endometrium. So menorrhagia because of increased estrogens causing hyperplasia, or if not technically hyperplasia, causing at least more proliferation of the endometrium. Maybe it is not enough to call a hyperplasia, but there is too many glands, more than a normal woman will have. So menorrhagia could be a presentation.
Question 19. What is the underlying reason for the symptoms experienced by a type 1 diabetic mother who underwent a cesarean section for preeclampsia, is currently receiving magnesium sulfate infusion, and is now exhibiting delirium, drowsiness, a respiratory rate of 10 per minute, a random blood glucose level of 240 mg per deciliter, oliguria, and bilaterally absent knee reflexes? Your options are, and the correct answer is magnesium sulfate toxicity. Here's the explanation.
Suppose the patient delivers at 10 a.m. today, then you'll give the injection at 2 p.m., 6 p.m., 10 p.m., 2 a.m. in the morning, then 6 a.m. and then 10 a.m. tomorrow morning. So you have to go on giving for 24 hours, 5 grams. But suppose she throws a convulsion tomorrow morning again at 10 o'clock. Then you have to give it till day after tomorrow morning, 10 o'clock. So whichever is later. So continue Maxel for 24 hours after the delivery, or 24 hours after last convulsion. Whichever is later, not earlier, whichever is later. Alright, so when you're giving this Maxel for 24 hours, the maintenance dose when you're giving this, you must monitor these three. Of course, you should monitor the other parameters also, like the pulse rate of the patient and the other parameters like the blood pressure. All that also has to be monitored. But for giving Maxel, what is the specific management? That is what is a very hotshot MCQ in exams. So when you're giving this Maxel, you must see the knee jerks and the respiratory rate. Knee jerks should be present. Knee jerks should be present. At least minimally they should be present. You know, knee jerks have 5 grades, 0, 1, 2, 3 and 4. So minimal knee jerk should be at least present. Respiratory rate should be more than 14 times per minute. Why? Because magnesium sulfate is a cerebral suppressant. MgSO4 suppresses the brain, central nervous system. So when it is going to suppress the central nervous system, it's good because we're going to stop the convulsion. But too much of suppression is going to reduce the respiratory drive and cause the patient to go into respiratory arrest. So that's why knee jerk should be present. Why knee jerks we are saying? Because it is a knee jerk is representation of the upper motor neuron. It's an upper motor neuron reflex, knee jerk. So if the brain is suppressed, then the knee jerks also will be suppressed. So knee jerks, respiratory rate should be monitored because the magnesium sulfate is a cerebral suppressant, and urinary output should be more than 100 ml in the last 4 hours, because magnesium sulfate has renal excretion. It has renal clearance. So that's why urine output should be at least 100, and then only we are very sure that the Maxelf is also getting cleared out from the body. So please remember, knee jerks, respiratory rate and output should be seen before every next dose of Maxelf. So if any of this is bad, monitor these. If even one of this is not appropriate, withhold the next drug. What is the management? This is a MCQ. If any one is short, if any one of this is short, short of expectations, I mean to say, then withhold next dose. Withhold the next dose. Now, what is going to happen if the magnesium sulfate is not cleared properly from the body? So, that is what is going to be called the magnesium sulfate toxicity. So, magnesium sulfate, the first sign of toxicity comes at 8 to 10 milliequivalents. The therapeutic I told you in the previous screen is how much? 4 to 7. So, 8 to 10 milliequivalents per liter, you will get reduction of the knee jerks. Knee jerks are suppressed. So, this is the first sign of magnesium sulfate toxicity. I'm writing just tox. All right. Then 8 to 15, you will get respiratory depression, respiratory suppression, you can say. And 12 to 15, you may get respiratory arrest. And 25 to 30 milliequivalents, you get a cardiac arrest. So, that's why we say monitor the max self, and if the max self is not cleared properly, these can happen. So, what is the treatment of the magnesium sulfate toxicity? Please remember, the treatment of magnesium sulfate toxicity is to give the patient calcium gluconate. All right.
Question 20. A 28-year-old woman with a history of multiple sexual partners presents with lower abdominal pain for 1 month. She experiences minimal discharge, menorrhagia, and menometrorrhagia. What is the most likely cause? Your options are, and the correct answer is Neisseria gonorrhea. Here's the explanation.
Women have pelvic inflammatory diseases. They can be because of many organisms, and it can be common organisms like chlamydia, gonorrhea, ureaplasma, mycoplasma. It can also be tuberculosis. Now, tubercular PID is a common cause of PID in our country, but not the commonest. Pelvic inflammatory disease in Indian women happens just the way PID happens all across the world, and it is because of chlamydia, gonorrhea, ureaplasma, etc., etc., and maybe also tuberculosis. But don't say tuberculosis is commonest. All right. So, tubercular PID we've discussed in a separate chapter in the app. Now, we are talking about the inflammation of the pelvic organs because of all the organisms put together. Tubercular PID, we've given a stress about it in a different chapter. Right. So, when we talk about PID, the commonest cause of pelvic inflammation in women are because of chlamydia and gonorrhea. So, most common cause of PID in India is chlamydia. But yes, people don't come to you with the symptoms of chlamydia because it's prevalent, it is the most common, but it's an indolent PID. Indolent means symptomless. It's a symptomless PID. The patient may be having chlamydia, but she never presents to you, especially if she's already had children, because what chlamydia does, it causes the inflammation of the pelvis and the tubes, and it'll make the tubes not have a transport of the oocyte, blocked tubes maybe, and that inflammation causes infertility. But now the woman is already 35 and she does not have to have a botheration of having children. So she's not having any of the discharge, she's not having any fever, she's not having in pain abdomen. It's an indolent, quiet PID. So that's why women will not come to you with symptoms of chlamydia. If you go, suppose you're doing a pilot study, you go to one society and you say that, okay, fine, there are 300 women here, and around all these 300 women, I'm going to do a chlamydial serology. You'll be surprised that maybe some 30-40 women will come positive, maybe 50 may come positive with chlamydial serology without them having any symptoms and without them knowing about it. So that's what you see in chlamydia, that there are no symptoms. It's an indolent PID. All right. Now, gonorrhea is that most common PID presenting to the outpatient department because it is symptomatic. So the patient with gonorrhea may have symptoms like lower abdominal pain, a vaginal discharge, dysuria, painful micturition, or may have irregular periods, may have menorrhagia, heavy periods, or may even have a menometrorrhagia. that is irregular periods without any pattern. So these are the ways gonorrhea can present to you, and most common symptomatic PID present to the OPD is this gonorrhea. Most common prevalence wise is chlamydia.
Don't forget to like and subscribe if you found the video interesting. Thank you for watching.